Hola, ¿qué tal a todos? Gracias por estar aquí con nosotros otra vez. Tenemos un panel hiper destacado. Los dejo ya con el doctor Schoenecker para empezar este nuevo tema de cadera. Dr. Schoenecker.
Lydia, thank you very much. Lydia is our most competent translator who, with Adriana, makes this possible with the simultaneous translation, Spanish to English, English-Spanish. So it's our sixth conference. This is on slipped capital femoral epiphysis, acute, chronic, and late presentation. Again, Bibiana has been instrumental in making this happen. Thank you, Bibiana, from all of us. The faculty that will be working with us from South America and the Garrahan Hospital with Bibiana, Dello Russo and Martin D'Elia from the Garrahan. Matisse Sepulveda from just south of Santiago, Chile is with us. Christian Fuentes from Bolivia. Those are faculty members. And then we have two fellow physicians from South America in Buenos Aires, Santiago Iglesias and Gonzalo Magno. Sorry about the pronunciation, but you're stuck with me, so that's the way it is. Ira Saltz from Detroit. Thank you, Ira. We see Ira. Peter Stevens from Salt Lake City. Thank you, Peter. Xuemin Lou. I don't see Xuemin, but maybe he'll join us. Deborah Eastwood may join us from London. Jonathan Schoenecker from Nashville. Eric Gordon, as I told you, unfortunately is doing trauma call on OI children this morning who arrived at our adult hospital as young adults. And myself from St. Louis. And I see Kay Wilkins, who's an honor member of our group. Thanks, Kay, for being on. So the faculty, if you have conflicts that has something to do with changing your thoughts of the world or the life or this, please let us know now. Jeff Nepple is with us also. I forgot to put him on the marquee, but Jeff is with us from St. Louis, and so welcome, Jeff. So we're going to talk about definition, assessment, and goals. Surgical treatment options, of which there are many, many with slips and residual deformity in particular. And hopefully we'll spend a lot of the time sharing our thoughts back and forth, which is, I think, the essence of our program. So I'll go with a little bit of short didactic here. If anybody wants to comment, please, anytime, talk. It's a typical slip deformity. The metaphysis, for definition to start, displaces proximally and externally rotates. The femoral head slips somewhere, maybe posterior to the metaphysis. On this cadaveric specimen, we see a variable severe metaphyseal deformity and bump. And the bump is a bigger part of the problem, plus often the severe external rotation deformity of the extremity distal to the slip. So as it occurs, thank you, Ed Abraham, for this video. And this is how it sort of occurs. It interferes with flexion. So every time you flex, you must externally rotate. Notice the bump impacts pathologically on the acetabular edge anteriorly and laterally. Abduction can be affected also on severe enough deformities, as we see here. So how do we classify slips for discussion? Let's talk about whatever duration means to us, severity, and stability. Duration is a little here and there, I think. Usually it means there's more problems in the last few weeks. It could be a stable slip that became sore. It could be an unstable slip. And historically, the best I can figure out, 60 years ago, if you had a history of a slip for less than 3 weeks, you were taken to the OR for a rather traumatic attempt at reduction. And if it was less than 3 weeks, people realized at that time, you can maybe get that to work. If it's more than 3 weeks, that probably won't work because the slip is stuck and you may cause more damage. So that's historically where acute and chronic came from. But now most of our slips present are chronic. They've been there for a while. And often there's an increased symptomatology in the last few days that brings them in. It could be that they just have impinged so much that they got to have something done, or it could be that the physis becomes more unstable and it suddenly changes into what we call an unstable slip. Severity. We assess by the slip angle, the Southweak angle, but we also try to grade the best we can the bump, metaphyseal translation deformity. So the Southweak angle is you outline the epiphysis perpendicular to the opening of the epiphysis, and then the best you can and line down the shaft, which gives you the epiphyseal shaft or the slip angle. And where you go down the shaft, as you even can see in this diagram, is a little bit somewhat inaccurate at times. A mild slip angle, a moderate, and as it slips off more, a very severe 70-degree slip angle. Notice the bump gets bigger. So maybe we can classify it by the size of the bump, which our result has tried to do, I believe. So there's a smaller bump and a bigger bump. Ira, one time you talked about work you've done to try to come up with a classification system, but I believe you told me that it was kind of hard to really quantify it. Can you comment on that, or was it not useful?
Well, I think we kind of got a finer appreciation for the tremendous variability in the morphology of the upper femur. And there's a lot of factors: version, translation, tilt, and extent of remodeling. And it's really hard to quantify all those into one uniform system.
Okay. So residual metaphyseal bumps might be labeled as small, moderate, and large. And that may be misleading sometimes to your following patients, because sometimes the bigger bump is less of a pathological problem than the little bump. Why might a smaller bump become a pathological problem? And this was brought to our attention, I think, very nice by the work of Mike Loenig, the son-in-law of Dr. Gans, in a publication a few years ago. The smaller bump can get into the acetabulum, and then we call it an inclusion bump. And it can cause damage. If you think about it, the smaller bump people, once the epiphysis is stabilized, can do more. So they may get by at first with moving their hip around, playing basketball, whatever, but they may be doing significant damage to the inside of the acetabulum. When I presented things that we talked in the past, we would say this is a remodeling bump. It's kind of a moderate bump. And we say, well, that's good, you're remodeling. But it's, if you look at it, there's no offset there. It's just a huge cam machine. It's a pathological setup. And maybe you don't demand too much of your hip and it looks like this, so you say you've remodeled into an okay situation, that may be. But every time you force that hip in, you force the epiphysis out the back, and it can cause a lot of trouble. So we remodel a little bit, but I don't think that much. This is the big bump, and it impacts against the edge of the acetabulum, and it doesn't do too much damage inside, maybe, but it probably does cause ossification, more likely on the edge of the acetabulum. Anybody in the faculty, any comments on the pathologies of the 3 bumps I showed?
Barry?
Yes.
At least in this example, the bigger the bump, the more prominent the lesser trochanter, which suggests how much rotation plays a role in this. And that's not estimated very well on plain radiographs. nor on CT scan unless you include the femoral condyles.
A preamble to the case that Peter's going to show a little later. Thank you. About stability. And Dr. Loader came up with sort of, I think, to me, it was sort of a new beginning or a new understanding of what stable and unstable means. But it's a pretty good start. It's a few imperfections in it, what unstable really means. But when Randy wrote this review paper of a lot of cases taking care of it, when he was, I believe, a fellow at Scottish Rite, Dallas, he decided that he was going to call stable slips a patient that walked in to the doctor or to the hospital and they could walk, with or without crutches, but they could walk. An unstable slip meant that maybe the slip gave way when you're walking, but you can't get comfortable even with crutches. It was almost more like a femoral neck fracture. And so that's what he came up with. It happens though, like when chronic goes to acute, suddenly a stable slip can turn into an unstable slip, and that can be a catastrophe. So this would be a significant slip, but the patient's walking without crutches, and it's a fascial stable slip. And it's also a Loader stable slip. This is a femoral neck type fracture almost. It's a fascial unstable. This patient hurt for a couple of days after getting bumped, but then reached down to tie his shoe. He was 12 years old and his hip gave way and he couldn't stand up again. It's kind of like comes a femoral neck fracture. So it's probably a Loader unstable. It may be also a fascial unstable too. What happens is at times is the fascial stable slip may be doing things and they may be playing football or something. And suddenly they just get pushed around in a pile up so hard that their hip gets jammed and hurts. It isn't necessarily fascial unstable, but they decide they can't walk anymore. So they bring him to the ER, and you can get misled saying, well, he can't walk, so he's got a fascial unstable. And if you take this hip on the left to the OR, think I'm going to reduce this, you're in for a awakening, it won't reduce. So you have to differentiate that. It's happened to me more than once where I was set up from the ER by the staff helping with the patients to go to the OR that night, and we realized we really had in the holding area, we really had a sore stable slip. And then when we talk about unstable, does it move, which John Schoenecker will show us with some of his videos later, underflow or doesn't move. So if you have a stable slip, the acute epiphyseal displacement occurs as the epiphysis begins to slip, as we can see here, E going off of M, the epiphysis off the metaphysis. That looks pretty innocent. But if you look at it with a scope, it doesn't move. It's like a fracture. And when you first see one of these, either open with an arthrotomy or with a scope, you're impressed how much the periosteum is torn and how much it looks like an acute, not very nice fracture. So the goal of this, as we all know, is to stabilize the slip and go from there. That's for the small slip. A bigger deformity presents stable, acute, maybe on chronic. Again, surgery to correct loss of stability, and maybe then further surgery laser for functional problems as we follow the patient. So pinning is what we all have to do if we take care of ER patients. And I'll turn this over to Jeff to take us through Nepple, where he sees the problems and the issues to deal with and taking care of this. So Jeff, here you go.
Sure. So I think pinning's a pretty simple procedure, but when not done right, screw impingement can cause problems as well. So we seem to see that some in our practice. So you can do this on a fracture table or a radiolucent table. I like the fracture table because nothing's moving around. You have sort of a stable base. We want to get the screw. In this case of a stable slip, generally one screw, fully threaded screw in the center, perpendicular to the physis. As you get into more severe ones, sometimes you have to compromise that. For the trainees as well, we want to avoid that screw, the pin penetrating while you're drilling. It can get bound up and pushed into the joint. So I think Perry and I both like these long pins that we can kind of hold so that it doesn't bind up as well. So a simple thing, I think threaded screws protects you. Many of these patients will have procedures down the road, and much easier to get a fully threaded screw out than a partially threaded screw.
Jeff, you're going to get warned by the translator. There's 21 syllables in everything you say in Spanish that are in English. So
sorry, go slower next time.
You say, please slow it down. Go ahead.
So your starting point is critical. It's easy in a mild slip. As you get into more severe slips, you want to consider the intratrochanteric line and making sure if you are in the joint, your screw is behind the deformity, not making it worse. X-ray can fool you. You want to know where that's entering bone, so really check it before you start drilling.
I add to this for you, Jeff.
Sure. So this is getting into more severe slip. You have to, in some cases, compromise staying out of the joint with staying perpendicular. But again, there, even on the right, staying behind the deformity and making sure your screw is relatively down so it's not sticking way out of the bone.
Anybody else on the faculty, Bibiana or Martin Dialia or Matisse or Christian, have any comments? Screw placement?
Yeah, Perry, Eduardo Novaes show us to use a biopsy guide rocker for the starting point. So when you have these very heavy slip heads, you have to go into the neck and it's more sleepy. So you can use this biopsy guide drill to start the point.
Yeah, for these cannulated screws, we do a very similar thing, Matisse, by taking the actually the reamer or the drill itself, and I use that with my hands just like you do to put the pins pointing exactly where you want it, or it won't go where you want it. Good point. I think that's what your trocar biopsy guide does, correct?
Right.
Yeah, I think many of the poorly placed screws, people thought they're okay with the guide pin, but they slipped further proximally and they end up with a poorly placed screw.
Well, we're going to show you a couple, everything we're showing here, we did, or all of us did. So this is.
Perry, before you go on, I have a comment on that. When I put my screws, they're all cannulated. And then what I'll do, I try to put them in as close to the subchondral area as possible. I will take a needle and I'll inject radiographic material in there, and to make sure that it doesn't actually go into the joint. And usually when you put the needle in there, if it's still in the epiphysis, when you do it, you just get kind of, you can see the material just gets in the bone. But if you're out of it, of course, then you get an arthrogram, and that tells you that you're out. So that's a good way to confirm that your screw is not in the joint.
Thank you, Kate. So potentially later problems of this technique can happen. So screw length, Jeff, any comments?
Yeah, obviously, as you get into more severe slips, we want to have enough purchase to not allow it to continue to progress. So as many screw threads across the physis as possible. This study saying 5 gives you less risk of progression. But certainly you want to watch on the other side, as Kay said, to make sure we're not getting too close to the subchondral surface.
Okay, so we're out of sync here just a little bit. So this is, be careful of the anterior neck screw placement. So this is a case we did a long time ago. And we realized we're medial wet, a couple weeks later. We watched the patient very carefully. The screw was down tight on the neck, we thought. And the problem finally became to the point where the patient said, this whole hip problem is really bothering me. This slip hasn't got any more, the growth plate's closed. And this is a pathological problem. If you're putting a screw anteriorly, you have to be aware of this, don't do it, or take the screw out sooner. So this was so much of a problem that we had to explore this joint. And just to show you some anatomy that can happen with a screw and a bump that are still there. So this is looking at that left hip, the surgical hip dislocation. Labrum is labeled. The metaphyseal bump, the screw. What happens if we flex the hip as looking at it? The bump and the labrum, everything impinges in a very negative way on the labrum. So if we look at the bump and the screw, the acetabulum, there's a huge tear in the labrum. So the anterior screw is a real issue. And you just got to be aware of that, and certainly don't do exactly this here. Now the bump itself did some of this, but the screw's right in there with it. I think the other thing that we see within the second problem that sneaks up on you that you may not be aware of. So this is a tall basketball player who's got a slip, some external rotation. Screw looks pretty good, doesn't look too medial. She did okay, and she was sent back to play basketball. And after 5-6 months, she was a very competitive. She said, I just can't do it. So we kept looking at why she can't do it. Because if you look at this, the slip deformity isn't too bad. The motion was a little sore in flexion, and internal rotation was blocked. The screw head by the article Goodwin and Wenger put together looks pretty good. The intertrochanteric line shows that the screw's probably okay. But what you don't know is where the screw shaft goes into the bone. The entry site is one thing, where the end of the screws is another. So we got a CT, and wow, look at that screw. So
Hey,
that,
Perry,
yes,
another way to anticipate that is to take a false profile lateral view like we do in hip dysplasia. And you may see the screw sticking out just like that bottom right picture.
when you're in the OR.
No, in the clinic, take a false profile lateral. It's a good way to look at skiffies
Right.
before and after treatment.
And I do my pinnings on a flat table, and at the end of the case, Peter, I do that exact same thing to show myself that my screw, though it's a little medial, it's down on the neck.
Yeah, I do the same.
So this is more often a problem now. I mean, this is an impressive problem. So I think it's something to be aware. Any comment by any of the faculty? Besides Peter's?
I guess I would make one comment, Perry. I think that, we train everybody to try to put the screw in perpendicular to the epiphysis, but really you just want the screw to be in the center of the epiphysis. And oftentimes, if you have a very anterior starting point, you're really going through reactive bone and metaphyseal bone, and you don't get a very good purchase. And so I think in the severe slip, it's better to hug the posterior cortex of the native femoral neck and have the screw end up in the center of the epiphysis, but not necessarily traverse the physis in a perpendicular fashion.
Sort of like the middle picture shows here.
Yeah, but even like translating the screw more posteriorly.
More posteriorly, right.
Yeah.
I completely agree with that. What I was saying is that usually ends up being the ideal trajectory without causing problems up front. Another option that you can do is there's a lot of good headless screws that are available. And we've been using those for about a year now, and so far have not had a problem with them.
Jonathan, and for removing those screws, do you have done it already?
Yeah, it's nice, especially, and I'm not going to mention the name, we're not supposed to do that, but a lot of these companies now have their headless screws are back cutting. And because of the way that they get compression, the conical aspect makes them easier to back out than put in.
Okay. So following initial successful stabilization, it's essential to monitor our patients if you want to know what's happening to them. And maybe appropriate other treatment is necessary, which it often is, which it would be for a patient like this. Severity of the residual deformity varies. It can be mild, more severe, quite severe, and very severe. So as the variability of the deformity varies, so does our treatment, and there's all kinds of ways to do things, and our skills are different, and our outcomes can be similar even though we do different approaches. So that's what I think most of the rest of the program is till we get to the unstable slips.
Yeah. Perry, I got one other comment about the screws. You want to make sure it's not in the superior part of the epiphysis, because it can hit those blood vessels where the blood vessels go into the epiphysis, and you can get a little localized avascular necrosis. And I've had that. We used to have that problem when we used to use the multiple pins, but I think the important thing is make sure you stay out of that superior portion, because you can hit those blood vessels up there and you can get a segmental avascular necrosis. Has anybody ever had that problem?
Yeah, we'll show a couple of cases at the end showing that, Kay.
Okay.
Thank you.
Sorry?
So, yes.
Also, it's important to say that sometimes the severity of the residual bump does not correlate with the symptoms of the patient, because all kids have a different demand. So a small bump can be very annoying in a basketball player, but a big bump maybe doesn't, in some kids doesn't bother because they do not a sport, they don't flex completely the hip. So it's important that.
Leads us into a case we're talking about. Thank you, Matisse. You're clairvoyant, knowing what's coming in the future, I guess. So here's a very hardworking farm boy, 10 years old, bilateral hip pain, small slips, stabilized, comes back to see us 9 months later, can't walk up the steps in the barn because he has pain. And the lateral bump is minimal, but there's a small anterior bump. It's an inclusion bump. Slip isn't slipping anymore. The growth plate's beginning to quiet down. So Peter was just talking, I took him to x-ray, and there's a lateral false profile x-ray. And I had him flex his hip till it hurt. And we're able to catch this small bump. And right here, he said, my hip really hurts. There wasn't much rotational deformity. So this is, as Lenny pointed out, the bump that can really tear up a hip. And when we get to Ira's case, we'll show the same thing later. And so what to do about this? So a small bump damages things, as you see here on the arthrogram, excuse me, the scope picture from Leunig. You can see the tear in the contralateral junction. You can't see the bump here because it's off the screen from the metaphysis. So there's the damage. So your treatment approach might be proximal femoral osteotomy, arthrotomy, scope. We're not going to do an osteotomy unless you wanted to do some big extension osteotomy, which most of us wouldn't do for this nowadays. I know how to do arthrotomy, and I've done an anterior arthrotomy for decades, and that's what I would do. my partner, Jeff Nepple, would do a scope, and that's probably a reasonable way to treat this. But if you don't have a scope, you can do an anterior approach, and you can easily expose the bump, and you can excise the bump. But if you understand the anatomy, you'll realize that there's a vessel on the other side of the little mountain here, and the vessel is very important. So you're a little intimidated with just an arthrotomy to go too far. But for this patient, it solved the problem. The other slip did the same thing 2 years later, and Dr. Nepple solved his problem with a scope on that time.
Perry, one comment on that.
Yes.
So I think we realize more and more in slips how variable they are, and that frog x-rays often don't show the deformity. So I've seen many residual slips with pretty good looking frogs, but you take a done view, which we use in FAI much more, and you realize there's a more substantial deformity there than what the frog x-ray would let on. So I think you really need to comprehensively image it to understand where the deformity is compared to just relying on frogs, which we used to do in the past.
Jeff, in the slower English for all the many attendees, could you please explain what a done view is?
So in FAI, I think the most common view we've come to use is the 45-degree done radiograph. So it's 45 degrees of flexion, 20 degrees of abduction, and neutral rotation.
It shows an anterolateral bump the best, correct?
Yeah, and we have some work coming out that shows more severe slip deformities than the frog would show you.
A little more severe deformity, unless somebody else has any comment. This is 4 months post-stabilization. That pain went away, but the person's doing more with activities, and they got a toe-out gait deformity, and they're complaining of hip pain, groin pain. So there's a little bump laterally on the anterior posterior view. I don't have it done. There's an anterior bump on the frog, in which Dr. Nepple saying between the lateral and the frog, there would be a bigger bump on the done. So you got hip pain and a deformity in the way he walks. They try to ride a bicycle. His foot will come off the pedal, or his buttocks will come off the seat. And about half the people, when you ask them about this, they sort of start breaking up laughing and say, I tried it once and it was a disaster because I crashed my bike. So the problem is he wants to function better and get rid of some of his hip pain. So we think of an osteotomy to rotate the femur, and that's probably what we would have done 35 years ago and stopped there. But then we start thinking about the bump, and maybe we'll do an osteoplasty. So how do we do that? The approaches vary, and there are all different ways to do this. And I think you should understand with this approach, with this problem here, you can get a good outcome from a lot of different approaches. You can do a single anterolateral Watson-Jones approach and do an osteotomy and to some extent take off the bump. You can do a lateral incision for the osteotomy and an anterior approach for the bump. You can do an osteotomy and an arthroscopy, and the arrows look like I'm confused, but you can really do the arthroscopy first and then the osteotomy, or vice versa, do the scope first and then the osteotomy. And you might be the person that says, I want to do all these with a Gons type surgical hip dislocation. But I'm telling you, having watched all this being done and participated in all of them, you can get a nice outcome with variable approaches. The more lesser severe deformity like this lends itself to the less invasive procedures, I think. And this is what I picked to do for this patient. So you can do a neck osteotomy way up high, and some people can do that if there's a risk of AVN that keeps most of us away from this area. You can do a lower neck osteotomy, but again, there's AVN concerns and you don't get quite the power. You can do the transtrochanteric, which I think is also called the Sukiaka by those who are really into the osteotomies. And you can do the Southweak, the in-house or the workhorse, which is far away from the deformity, but it's relatively safe. So maybe, Ira, you've done as many osteotomies, been involved in this as much as anybody else, up to the current ability to do a total dislocation. What about your thoughts on the use of osteotomies?
Well, I think in general, we do fewer osteotomies nowadays than we did before we really understood the intra-articular deformity, as you mentioned. And when we do an osteotomy, we do less of an osteotomy because we have the ability to do things intra-articularly, and the combination of intra-articular surgery and an osteotomy is more powerful than either one alone. And I think that's led to general improvement in the results following osteotomies, because when we used to induce these huge compensatory deformities in the upper femur, though that compensatory deformity had significant consequences to the movement of the hip joint, and I think we underappreciated some of the problems that we caused in our attempts to realign the epiphysis, particularly in the posterior aspect of the joint and the ability of the patient to extend fully. So I think that our technique has really improved substantially with the ability to do intra-articular surgery and to manage the morphology of the neck of the femur and the epiphysis.
Christian Fuentes from Bolivia, any your thoughts on how you like to approach deformities with osteotomies? Martin, Elia?
Hello, Barry. Hello, everybody. You know, I really, passing the years, I really prefer to do surgical hip dislocation for these approaches because, as Ira says, you can manage all the extra-articular and intra-articular in the same approach. For me, it becomes so easy if you becoming familiar to the approach. For me, you have the best chances because you show us that we have not only a slip, we have a rotation deformity. And sometimes when you do the extra-articular osteotomy, if you don't see intra-articular, perhaps you create another deformity. And you have to manage this in the same way. And for me, it's not a lot of approach, doing only a transocateric osteotomy to go into the joint. I don't know if you understand the approach.
Yeah, we will go through various severities, and it'll be obvious that sometimes one approach is much better than the other, or they're all similar what they can do. So this is how I've approached these deformities before we got to surgical hip dislocations. But this is a very simplistic drawing. It's going to be an intertrochanteric Southweak osteotomy, fixed like Imhauser. There's a bump. There's the osteotomy, rotation, maybe a little flexion. The bump is easier to approach than with an anterior approach or with a scope. And the bump's got to come off. We actually, I mean, I've been interested in the bump. We've been doing this for decades. They has take the bump off. So there's anterior, posterior, pre. There's after the Imhauser osteotomy. And there's the pre-op bump on the lateral profile. And there's the bump off on the side. Maybe could have taken a little bit more off. The lateral bump post-osteoplasty.
Sorry?
Yes.
I think since we have to consider also other factors for this decision, as in our clinical practice, we have patients that are from far away our cities, or right now, for example, with this COVID issue, we don't have a good rehabilitation therapy available because they are closed or they are working into COVID. So also, this is a good solution if you want to explain to the parents what is going to happen with it, because with the new locking plates, you can do this osteotomy and the kid will, if it doesn't ever come back again, it will be better solved sometimes with a trochanteric flip approach, because you don't have to be very in control of the patient. That's a thing that maybe we have to consider and explain to the parents sometimes.
Yes, this plate here, you have to be in control of the patient, particularly if this plate is used with an obese patient. This fixation is a little bit tenuous. Okay. 13-year-old unstable slip, reduced the instability part, little bump left. It was kind of a dramatic event. It was a baseball pitcher who was delivering a fastball. His hip collapsed at the game, which was kind of embarrassing. 1 year post-op, he says, no, the hip isn't quite right. I escaped problems with avascular necrosis that you warned us about. But he came to see Jeff, and he doesn't like that his foot turns out and he's impinging. So Jeff, what's your thoughts about approaching this and the things that you can do?
Yeah, so I think you need to know kind of activity that they're doing, how restricted the motion is going to be critical to making any decision about osteotomy. And then in the setting of intra-articular deformity, is it accessible for me with arthroscopy? Arthroscopy with a PFO has worked pretty well. That avoids the hit of sort of the surgical dislocation with the PFO, which just ends up to be a big hit on the hip if it needs it. So this would seem to be something we could access pretty well arthroscopically. There's a little edge on the AP view. Low dose CT can be very helpful to kind of make these decisions. But I suspect his rotational issue plays a role here, that some kind of combined approach.
So this would be, of those available, Jeff's choice, correct, Jeff?
Yeah.
And it's a bump that resides remodeling, and we talked that like it was a key to everything 50 years ago or 40 years ago. It isn't. And can you tell us how you do this, Jeff? Here you go.
So arthroscopy is a great tool if you do this a lot. These are challenging hips to scope. The deformity goes very proximal, almost into the joint, which you're not used to with FAI. You can take screws out through the arthroscopic approach and kind of look right at it as well, and then really do a thorough recontouring, but definitely a more challenging hip that you want to make sure you're adequately correcting if we're going the arthroscopic route.
The lateral retinaculum is there, Jeff. Do you usually have to see that to get this bump taken out adequately with the scope?
Yeah, you mean we see it great arthroscopically. I mean, as easy as you see it open, and then I think the challenge becomes going proximal and posterior to the vessels for some of these deformities compared to kind of the anterior bumps are much easier to deal with.
So here's a question for you, Jeff. Then femoral osteotomy. Is it always possible to do the osteotomy at the same time you do the scope?
Yeah, I think it depends on how extensive your scope's going to be, because you do lose fluid. The leg is swollen. So we've definitely had cases where we felt like we should probably delay it. If everything goes smoothly, I think you're probably in a reasonable position to reposition and do it in the same setting, which is obviously nice for the patient to have a one time.
And that's what happened here. John Schoenecker, I know in your situation, you work with a scope partner, a partner that scopes. How's your thoughts been here in the strategy? Scope first, then osteotomy, or osteotomy and scope? You do it at the same time? How does that work out for you guys when you do this approach?
Yeah, we've changed a lot over the last 2 years for our derotation. We've been doing a lot of our derotations over nails. And what we have found is that if I derotate first, it's much easier to scope because you can position the hip during the arthroscopy to get much more proximal, as Jeff was talking about. So we've switched over now where I start off, I do the derotation, get it so that the patient can be 45 internal, 45 external in extension, as we have a video later. And then we just switch over to the scope table and do the scope.
Ira, do you use this combination at all?
I do. I think that arthroscopy in SCIFs has really revolutionized things and given us a much finer appreciation of the pathology. I would say that actually I think it's a pretty straightforward joint to scope because we can see the physeal plate when you do arthroscopy. So you know the proximal extent of the resection, and whereas in a regular FAI, sometimes it can be difficult to understand how far proximal you need to go. In a SCIFy, you can see the physeal plate when you're doing arthroscopy, and you know when you're in the epiphysis, and you can do a very good recontouring. And unless it's a completely healed, mature deformity that takes on some secondary characteristics, it's a pretty straightforward joint to scope. And we do the osteotomy at the same time. But I usually like to do scopes supine and osteotomies lateral. So I do go through the inconvenience of repositioning the patient after the arthroscopy.
One other point, Pops, that I would like to add on that is, as we'll see in a video later, is it's pretty remarkable how much flexion you gain back after you do the derotation. And one of the hard parts, I think, of doing the intra-articular work, both open and through arthroscopy, is knowing how much to take off before you're done. And for us, we pretty much make it a goal is for the intra-articular aspect is to have 90 degrees of flexion with at least 15 degrees of internal rotation. And I think that's one of the advantages of doing the derotation first, is you gain so much of that back, is that it often makes it so that what you have to do intra-articular actually ends up being a little bit less and probably a little bit more safe in terms of avoiding taking too much of the femoral neck.
John, that's a good segue to, I think, a critical question is flexion's always been a big part of these osteotomies in the past to bring the weight-bearing articular surface up. Not correcting that, I think, is a little easier technically, but I'll be curious what the panel thinks for do you need to flex these osteotomies?
I think that's a great question. And Pops, are we getting in that now or later?
Yes, we get that. We can go that anytime. But let me ask. Yeah, I was going to ask Matisse. Matisse, you heard the question that John and Jeff are talking about. What do you like to do with your osteotomies? Is it all rotation, or you do some flexion? What about Matisse?
When we perform the osteotomy at the same level that is in the picture, the hip tends to position itself in a good way. It's very interesting how after you do this osteotomy, the hips tend to be in the good place. So usually it goes with a little flexion, like in the picture in the bottom. But looking at and hearing what Jonathan is saying, probably if you do this with a nail and you are not getting this extension, you will be working this on the intra-articular with the arthroscope. That is what we also do, that we look with an arthroscopy into the hip.
Martine, any other comments about what the goals of osteotomy are? That is regarding rotation and any flexion to it.
No, I agree with Matthias that when you do the flexion, the rotation first, you gain some sort of flexion. So then I decide how much flexion I have to do. But I have to repeat that for me, it's not a lot of approach that if you, in the same procedure, you do the trochanter flip and you go inside the in the interarticular and then you resect the bump. Sorry, I insist.
Hey, Perry, can I make one comment about this? So we focus, and I alluded to this earlier, we focus all of our attention on the anterior aspect of the femur. But if you look at the pathologic specimen that you showed, and if you get 3D CTs on these patients, the epiphysis, the head, becomes very close to the posterior trochanter. And when you do a lot of flexion to correct these deformities, that posterior deformity becomes very mechanically significant, and it affects the ability of the hip to extend and limits range of motion. And we saw this in a study we presented at POSNA like in 2012. And it's a real concern in the high grade deformities. And really, as John said, and as Jeff said, rotational correction is really the key here. And doing a lot of flexioning your osteotomy can be very unpredictable and potentially dangerous to the hip joint.
Peter, we're going to show your case, but you want to chime in a little bit, Peter Stevens?
Yeah, our comment in passing is nowadays all these patients should be screened for vitamin D deficiency because it may be an issue, especially bilateral in younger patients. But anyway, I think the acquired retroversion is the primary issue. All the radiographs we take are not really representative of that. So I would favor an antegrade rod, mid-diaphyseal osteotomy, rotate them on average 45 degrees, as John indicated, so they have equal inward and outward rotation. They can typically flex to 100 degrees and stop there and let the patient decide. You know, they're going to have rod removal in my practice. Let them decide if there's a residual impingement or somebody's concerned about a bump, then they can be scoped electively. And the advantages there, you'd avoid producing deformity in the proximal femur, which the total joint people will thank us for, and you don't have broken screws or retained hardware in the proximal femur, and there's zero incidence of necrosis.
So we spent a fair amount of time on this, but if you're into osteotomies, I think it's a very important discussion. I can tell you 40, 45 years ago when I started, to add flexion was considered very important to get that articular surface back up anteriorly, but it was maybe a little, that was one of the things we could do. So maybe that's why it was emphasized. Bibiana, any comments you have about how we're doing in the discussion of osteotomies? We've heard enough, or any other thoughts?
Perry, I think she's having some trouble with her audio, but you know, Deborah Eastwood is on the call. I think she wanted to say something.
Go ahead, who's talking?
This is Sabrina, but Deborah is here.
So it's Deborah Eastwood, Perry.
Oh,
so
Deborah, good.
Hi, no, I just
you're with us, good.
Of course, always. I just put something in the chat for Jeff because he'd said that if the arthroscopy had resulted in a lot of swelling, he maybe would do the arthroscopy and then the osteotomy on separate occasions. And that's certainly one reason why we would sometimes do just a limited anterior approach. So we feel that arthroscopy has really taught us a lot as to where the bump is and what we're looking for, but that we can accomplish most things through a small anterior approach. So if we would often do a small anterior approach and a lateral approach to the osteotomy if we felt both bits were indicated and get it all done on the same day.
Deborah, did you just join us or did you hear my discussion of what you just said?
No, I've been here all of the time. Yeah.
Okay, all right. I think we're doing great on time, but I'm going to keep moving. Okay, and we've already talked about this, doing the osteotomy back and forth, one or the other. I think we discussed that. Jeff, here's your patient pre-op, and here he is post. And this approach you continue to expand in helping us. Any additional comments, Dr. Nepple?
Yeah, I think the one advantage that arthroscopy brings compared to the open approach is dealing with the intra-articular work. These hips, you mean the slip you showed arthroscopic image is the least damage you'd ever see. Almost all the time, these hips have major cartilage and labral damage. Maybe it doesn't matter to treat it, but in some cases, I think you are finding things intra-articularly that may help down the road dealing with their labrum or cartilage flaps and things. We'd love to obviously get to these hips before they develop all of that damage, though.
Next case, 18-year-old patient of mine. The patient was very adamant. Lydia, I don't know how you translate adamant, very convinced. The only trouble he ever had was left knee pain. And he'd been telling doctors that for 4 years. Therefore, everybody missed the fact he had a big, bad slip with a lot of motion restriction. So we all know, but for everybody, all the attendees, everything, I mean, it's not uncommon for this deformity to be referred down to your thigh because of the femoral and obturator nerves going down your thigh quite a bit. So we actually one time wrote a paper trying to show that patients who presented because of knee pain on the average had worse deformities than patients who presented with hip pain. And we actually talked about that. So this is a big, bad problem. So surgery needed is to get, I think you have to take this bump off. You probably have to do an osteotomy. There may not be intra-articular damage. So these are the possibilities. Again, as before, you could do a Watson-Jones approach, try to deal with this, a single anterolateral approach. You could do separate lateral incision and anterior approach, as Deborah mentioned. And that's how I would have dealt with this 30 years ago. You could try to do this. It'd be a big scope case, right, Jeff?
Yeah, I think that's a bigger deformity, but an accessible deformity, because a big accessible deformity is much easier than a either small or medium deformity that's hard to get to. That's going to be right where we'd look at it.
And you can do what, let's see, what Martine is just waiting to talk about and doing. So Martine, how would you approach this?
Well, this is a mature operation. So perhaps I would do a lateral approach. Or I would do osteotomy, septoconteric osteotomy. I said before, for me, it's easy to in the same action, in the same approach, I add the trochanteric flip and do and see how the things do interarticular. For me, it's easy. Perhaps after this, in the second time, I add an arthroscopy issue, an arthroscopy Chester. But for me, you can solve all the things open in the same approach. It's not for me. It's not. I think so. Perhaps I have the luck to have my train with Teddy Longo and Gans 15, 16 years before. So for me, it's not a big surgery to go extra-articular and intra-articular in the same approach.
Xuemin Lou, are you on the call? Xuemin?
Yes. Yeah.
Okay, so what would be your approach of there's four choices, Xuemin, down below, single, separate?
I think this would be to do third one, lateral for osteotomy plus arthroscopy to make more congruence between femoral head and acetabulum.
So you would pick osteotomy and scope? Did I understand that, sir?
Yes. Yeah.
Okay. Peter?
So on the clinical exam, sticking with the theme, if you rotate him outward, say 45 degrees, and in that position he can flex past 90, I would do a mid-shaft osteotomy and rod and bumpectomy if needed. But you're effectively moving the bump posteriorly where it won't impinge, and it might not necessarily require attention.
Ira?
I agree with Peter. I would look at the physical examination, and I would likely manage this with a trochanteric osteotomy and surgical dislocation. I'd reshape the epiphysis as much as possible, and then I would do mostly rotational correction of the deformity.
Deborah? Deborah Eastwood?
Yep, I'm thinking. I mean, again, we've all highlighted that the clinical examination is key. I think that I don't think we would do a trochanteric flip for this. So I think that we'd be left with doing a proximal femoral osteotomy and arthroscopic if we could. I'm not the arthroscopist, and our arthroscopy colleagues often, as I said before, have a threshold for doing a limited open approach instead.
John Schoenecker.
So I would do a derotation with this first, and then looking at it, I haven't decided in outcomes which I think is better, is to do this through a troch flip or an arthroscopy for the intra-articular pathology. And so we kind of just go back and forth on it. With this size of a bump, just in terms of time of surgery, it sure is more satisfying to do open. You know, one or two chisel hits and then a nice burr and you're done. So the derotation for me is the first part, and so much of that comes from the physical exam at the beginning. And so I always examine these kids in extension to see how much rotation problem they have and start with that. And then after that, see how much sitting pain they'd have from the flexion.
Matisse?
I will completely agree. I will go for a lateral approach for osteotomy and scope for the deformity.
Perry?
Yes, sir.
One other comment on the physical exam is to do a prone torsional profile. And if it's unilateral, you can easily see the difference between the two hips and shoot for correction of that.
Just a side comment on that. I've done that for years, and I've noticed, just as an observation, not necessarily pertinent to this patient, but in general, if you have a bad problem with a slip on one hip or a poor outcome on a perthes, when you do the prone exam, more often than not, the uninvolved hip is quite retroverted on the motion check. So for me, retroversion to begin with is a setup for a worse slip and a worse outcome from perthes. That's
the other comment is that the retroversion may well cause mechanical knee pain. We've looked at this in the movement analysis lab. It may not be neurogenic as proposed. It could be mechanical because they're unaccustomed to it prior to the slip.
Okay, so that'd be myself with the help of working apart, John Closey and Jeff, said there's one thing we'd like to do with this. This goes back in time. Our thoughts changed. Jeff's changed us a little bit about, be patient and you can do a lot with a scope. But the transtrochanteric approach really does let you see what's going on. Dr. Gons helped us with so much to understand what's going on. So here it is dislocated and it's right in your face. When you see it, there's the bump. I've turned the x-ray so the surgeon's looking at this standing right here. And I think John Schoenecker said a couple of discrete cuts and wow, problem gone. And if you did this with a scope, Jeff, you'd be working for a while, correct?
Yeah, for sure. But I don't know. I try to not base it on how long it's going to take me, but what the recovery is going to be for the patient. So despite arthroscopy sometimes taking a while, those patients recover really fast. So I think it's better if you deciding if you can get the deformity or not arthroscopically, rather than how much time it's going to take.
So we feel that we.
Go ahead, Deborah.
So we feel that if we do a limited anterior approach, so not the flip and not the dislocation, but an open approach and just 2 hits of the hammer, I'm exaggerating, that we can get a quick recovery as well from that. So in selected cases, we feel the outcomes are not significantly different in terms of recovery from a scope versus an open approach.
So for those who haven't seen this too much, on the bottom of the head here, Lydia, the bottom of the head where the arrow is, can you see my arrow?
Yep.
Yes.
Okay. That's posterior and this is anterior. What I've found, I've done a lot what Deborah talked about, the anterior approach comes in right about here. And the problem is with the anterior approach, when you open up the capsule, this big bulge is all you can see. And it takes a little time and you get less intimidated to take as much off as you can. You tend not to get up proximal enough. And you know there's something back here like a big bad vessel that you're intimidated from by coming across here too aggressively. So that to me is a hard one to take this off well. And I think in the past, I haven't taken off enough from the front approach. But anyway, we did it this way with an open surgical approach. We took off the bump. And when you're doing it, you should be aware that there's the vessel. It's always there. You can really, as John mentioned before, really make this look nice pretty fast. The burr helps to really smooth things out. If, however, you add an osteotomy in this area, it becomes a little challenging because there's a lot of work done in a specific area. I know Ira's talked about this when we've been with them a lot. So this is what we did. We performed we call it an intertroch, but it was actually high. Well, that's about right there. You get a lot of hardware in a small area. Whether you use the locking plate or the blade plate, it becomes a little bit of a traffic jam out here as to how to fit everything in. And you got to get it fixed so it fits well. I think Matisse talked about this might be one that you wouldn't do on a patient who you don't have any follow-up guaranteed. Ira, any comments on how to make this, it's a little tricky putting this together well.
Yeah, it definitely can be tricky. I think it has to be properly planned out. It helps to refix the trochanter with a blade plate. If you're not accustomed to using blade plates, you can also use proximal femoral locking plates, as Matthias said, but the geometry of the correction is a bit more complicated when using a proximal femoral locking plate because it's not really a 90-degree angle. So you have to kind of think through things a little bit more thoroughly, especially if you plan to do some flexion.
There is a little flexion in this one.
Yeah. So I prefer to use blade plates, and I like the cannulated blade plates that are available because it's very, very easy to refix the trochanter with the cannulated blade plate, and it makes it a little less crowded because I see you fix the trochanter with screws in this situation.
John Schoenecker, any comments about your experience with doing this all in one spot?
Yes, because of the traffic jam that you see on your left x-ray. This and other reasons is one reason why we started switching over to doing some other approaches to derotate in particular. I think that although you've achieved a lot with this, the amount of patients that I have that much hardware over on the side of the trochanter like that, they usually want that out the day of surgery. Is that trochanter gets quite tender. And that's one reason why, I moved to even the headless compression screws on the trochanteric flip, is that I really don't enjoy taking hardware out that much. So anyways, I think you can do this elegantly through a intramedullary nail with the headless compression screws and have less of post-operative pain from the hardware that you put in.
And we'll get to John's case shortly to show that. Let's see, Martin, Diana, you were pretty strong about this approach.
Very, in the last years, I changed from this plate to the locking plate, because for me it's easier to do the correction. You can change the proximal correction. You can change the proximal correction during the procedure, and sometimes the blade plate, if you put the chisel in a wrong position, you have a big hole in the neck, and then you cannot change again to have a good purchase. Okay? So I changed, and now I do it with the proximal femoral plates, locking plates, and for me it's really easier, and you don't have this so-called traffic jam of hardware.
Matisse, any comments?
Yes, one thing that is very nice to use is the valgus osteotomy plate, which goes a little lower than this, so it gives you the trochanteric completely free to do whatever you want over there. So the plate is a little lower, and with the screws are going up, the valgus osteotomy plate.
Okay, with that plate, Matisse, I take it you're mostly doing rotation correction.
Exactly.
Yeah. Let's see, I'm going to keep moving here. We're doing so great with time. It makes me encouraged. And Dr. Colin Mosey's on, so we're going to, knowing he's not doing this right now, but he's been here for decades, we'll have him for a little oversight here at the end about what he thinks about all this newfangled things going on. So let me move on. So it's a bit of a log jam when you do this. And Dr. Gans points out when you do this dislocation, particularly when you're doing the Dunn operation, you have to take control of this patient. And as he would tell the patients, you've all heard him, I own this hip for 3 months. It's not yours. I own it. And his personality would make you respect that. Because if he told you to jump, you jump and ask questions later. And you really need to take control when you're doing this. This kid said, all my knee pain's gone shortly thereafter. And he did spectacularally well. And said, thank you for getting rid of my knee pain. Never had a bit of hip pain ever, pre or post. So I'm going to move on. So this is a patient of Dr. Stevens, and I've doctored the pictures the best I can so we can see this. And it's a very severe deformity, a stable slip. And I've taken some of the many slides Peter sent me. He doesn't know what I'm going to show, but he's going to take us through this and hold his breath when he shows what I show. But here you go, Peter. Here's your case.
Yes.
This is the girl.
Not in this patient, but if there was an acute or unstable episode, I would still do an incidental reduction and accept just one attempt by me, not the resident.
But not in this patient, Peter.
Not in this patient. And so in this patient, if nothing moves, I would pin it in situ. And if he can't flex the hip, do a rotational osteotomy midshaft with an IM rod, and then can deal with impingement electively as needed.
So we'll go through a little bit of Peter's rationalization. Can you go ahead, Peter?
Yeah, so if you see a slip that's pinned with the screw in the lateral cortex there's a good chance any severe slip that they will miss the target. And as mentioned earlier, somewhere in between these two is better. That second screw is perpendicular to the head. and will capture it better, but it could cause impingement. So I didn't put a third screw in this picture. But here, what I'm suggesting, and as have others, is that the primary deformity, perhaps aided and abetted by vitamin D issues, is a gradual or sudden retroversion. The head doesn't really slip anywhere. It's held by the round ligament. You know how tough that is. It's the metaphysis that slips. It's really a slipped upper femoral metaphysis. This would be a better terminology. And therefore, even if you have anterior hardware pinning, as in this case, there's plenty of room to put an antegrade transtrochanteric nail to deal with the retroversion. And by so doing, you mitigate against impingement and make flexion, solve the flexion problem without deforming the upper femur. You can do CT scans. If you do that, you should include the condyles in order to appreciate how much torsion is really involved here. So, you know, it's really an acquired retroversion of the shaft relative to the head is what this should say. And the clinical manifestations would be limited hip flexion and knee pain plus hip pain with impingement. And the obligatory out-towing when walking, when trying to, they can't ride a bike as you showed, they can't tie their shoe, they can't sit in a theater because of the impingement when the knee is neutral. So by correcting the retroversion, you may mitigate against the impingement and gain flexion as mentioned, as well as getting rid of the knee pain. And typically it would be 40, 45 degrees of rotation, anteverting osteotomy, if you will, to gain this full correction. So this is a patient showing limited with the knee neutral, could only flex to 25 degrees on the operating table. And as you have nicely covered, people may want to do hip procedures through a scope or open, and I'm not critical of that. Next picture. However, if you rotate him outward, he suddenly can flex to 100 degrees. So what I'm doing is leaving the hip where it is, doing a mid-shaft osteotomy, rotating inward 40 to 45 degrees to gain that hip flexion. And you're avoiding the anterior hardware. It's not impinging. You don't have a forest of hardware in the proximal femur. I always remove the rods, but that's a surgeon's choice. And leave the decision, you know, so here's a percutaneous osteotomy and gaining flexion with a knee neutral. And patient has negative Trendelenburg, can tie her shoe, bend over, resume her lifestyle to her satisfaction. And this patient did not require secondary bump removal. So no further surgery has been required.
Questions there for you, Peter. Do you have to do much FAI surgery after this? First question.
No, I would prefer it be done through a scope, and I refer to my colleague who does a lot of hip arthroscopy extremely well. So that's what I would do in that situation.
Jeff Nepple and I were looking at this and said, well, maybe you end up with posterior trochanteric impingement this way.
We have not noted that. And as mentioned, we did a small series published doing gait analysis before and after, showing improved kinematics at the lumbar spine, the hip, and the knee. So there's an aggregate benefit, but we did not see impingement.
Ira, would you think that that trochanter clears itself? You've looked at this. Any comments?
I mean, I agree completely with Peter. Like over the years, I've done less and less and less and less flexion and primarily rotation. You know, I haven't, to be honest with you, I haven't been courageous enough to leave the upper femoral deformity alone, but I don't do very much flexion at all. And I do primarily rotation. So I agree conceptually. That's that I actually think flexion is probably potentially bad. You know, on the case that you showed, you outlined the head of the femur and you showed the posterior head neck junction comes to a point. Well, that does a lot of damage when we flex these hips and try to correct the deformity. So I do think trying to leave the epiphysis in place is important, but I haven't really been, I guess, I haven't had the guts just to leave the head neck deformity alone as he has, but I'm intrigued by this.
Well, I would comment that there are probably a lot of patients out there who have slips and odd looking x-rays who don't present because they don't have pain, and they come to see us because of the pain and the restricted motion. And so if you can improve their lifestyle and you know there's a problem in the hip, but it doesn't bother them, it's really their choice as to when to follow up. The other advantage of the IM rod, of course, is more rapid healing and immediate or early weight bearing.
Christian Fuentes, did you join us from Bolivia? Matisse, any comments about where we should be correcting? You haven't done it, okay. Martin?
No, a comment, it's about, you know, for me, is because it's nice to do the osteotomy with the nail. I didn't do this before. So, but I want to ask you, Peter, if you don't do in the same approach when you put the screw. And I do an arthrotomy, anterior arthrotomy, and I can do two things. First, I can address the residual bump, and then I can put the screw in the better position I can to avoid an impingement because of the hardware.
Oh, Peter.
So it's a question for Peter. If you do this, you don't do an arthrotomy, a little arthrotomy.
No. I leave that to my colleague to do arthroscopy as needed, but I'm not opposed to it for those. I would do the osteotomy first. If they have a great range of motion, which they usually do, then I would stop there.
So Martin, you're asking about this right here.
So about the question. Yes,
put it
exactly, because if you see in the right image, you can do this head of screw is too anterior. So when I do the little arthrotomy, anterior arthrotomy, I can address both things, the bump and the better position of my head screw.
Yes, that would be fine. I have not had that experience.
Okay, in the same line of thinking, this is a 15-year-old, bilateral slip. John, this is yours. So I got the video, I'll turn it on and try to.
If you can keep it paused right here, don't hit play just yet. So this is a 6'4", 320-pound kid who has bilateral skiffy. And what I'm going to walk through is how we approach taking care of both the walking and sitting deformity of a child like this using an intramedullary nail. And in this case, we did a trochanteric flip. And so starting off, much like what Peter just went through, if you look at this deformity, the first thing you'll see, as Peter emphasized, is I think the physical exam is absolutely essential for you to understand what to do in the operating room. So go ahead and hit play, Pops.
How many kilograms did you weigh, John?
320. What is that, like 150, 160?
150 kilograms. Okay. It's a big.
And you'll see that I myself am 6'6" and don't compare to his size. So this is his exam right here. So Pops, if you can pause there. So as you can see, if you neutralize his version or put his knee straight up, if you will, his extension or his flexion is only about 10 to 15 degrees with his knee forward. And his arc of motion and extension is 0 to 90 out. So go ahead and play. So here is his maximal flexion with his knee forward. Hit pause. So the goal, I think you keep hitting reset, Pops, on accident. Make sure you're over the pause button. Where are you going? There you go, right there. And so the goals as you go forward with this are to leave the child so that he is 45 degrees internal and 45 degrees external in the prone exam, as Peter was talking about, and to get 90 degrees of flexion with 15 degrees of internal rotation. So go ahead and hit play. So as you can imagine, the setup for this with his obligate external rotation is difficult to decide how to position him. So in this case, what we decided to do is to go lateral on a pegboard. And if you can pause. And in this position, it's great because you can really assess the flexion gain that you have as you go. One big thing we've changed is that in terms of hardware pain, we do a lot of retrograde nailing for femur fractures, which we don't ever have pain from now. And so in the skeletally mature, what we've started to do with these patients is derotating over a retrograde nail. And we haven't had anybody complain about taking it out yet. And in this case, as you'll see, it made it very easy to do this in this position because of his obligate external rotation. So go ahead. So that's his maximum flexion. And again, he externally rotates. And as Peter was showing, if you externally rotate him, you can flex him way up. And so that's where we're going to gain most of our flexion. So this is inserting the retrograde nail. And if you pause, if you can pause there, great. And so what we do to set the rotation is we put a single pin external fixator on. And once we've locked distally and done our osteotomy, in extension, if you just grab the proximal fragment and impinge the hip in maximal internal rotation, and then lift the leg to the amount of internal rotation you want the child to have at the end, it makes it a perfect setup for locking in that rotation and makes it easy to get your perfect circles proximally. So go ahead and hit play. So here we impinge the hip, lift the leg, lock the external fixator, and it makes it very easy to get your perfect circles. Then you can also test to make sure it gives you all the flexion before you lock in proximally. So as you can see here, we're trialing how much flexion and how much internal rotation that they have. After that, we then go in and look and see if there's a bump. We either do this arthroscopically or through a dislocation. I know this child had a big bump, so we opened him up in the same position, took that down, and then this is the final range of motion showing that he no longer impinges. And that, as it goes through here, okay, let it go. You can keep letting it go. Then you can check and make absolutely certain that you have what you set out to achieve, being 45 degrees of internal rotation, 45 out, and then 90 degrees of flexion with about 15. And this is him coming off of the table. So we have 90, 45 in, 45 out with 90 and 15. And it's a very nice way to do this in the sense that, as Peter was talking about, you can let these kids weight bear on the nail. Obviously, with the troch flip, we give about 4 weeks before we let them weight bear. And in terms of the question of follow-up, it sure makes it easy to do this and not have these kids have to come back as much.
Very comprehensive correction. Segmental nails, excuse me, retrograde nails, you have no trouble with the knee being irritated at all, John? They have not?
No, we noticed there's a lot of new systems. The new retrograde nails, in fact, a lot of them also have, you can see how much I like removing hardware. A lot of them actually have headless locking screws as well. And in a situation like this, especially if you're doing a trochanteric flip, it makes it very easy to do that from the knee. You can do the retrograde knee nail because of the targeting, and that starting point is the easiest starting point in orthopedics. You can do that derotation with the external fixator very fast. And again, the macroscopic change it has in flexion in the physical exam lets you know exactly how much you need to do when you do the arthroscopy or the open procedure.
So Perry?
Continuation of your theme, Peter.
Yeah, just a quick comment. At the very end of that video, it's an excellent case. The left foot is pointing neutral, and I submit that his knee pain will go away because of the mechanical correction, not a neurogenic change.
I agree.
Peter, I think that you know, the mechanics at the knee can't be emphasized. We just submitted this year to POSNA a group of kids who developed valgus deformities of the distal femur after skippies, and there's a tremendous valgus stress on the knee that's painful for these kids.
We're going to move on. Our next patient is Dr. Lou from Beijing. I believe it's 11 years old, lots of limping, and again, a knee pain. Therefore, you present a young person with a huge deformity. And note the chronic severe slip. And Xuemin, you're with us, I believe. And there's notable right hip motion restriction, flexion, interrotation, and abduction. And maybe these are the treatments you would consider. So here's your options, Dr. Lumen and Dr. Lou. What would be preferred approach here, Xuemin, and why?
For this one, because this one is stable, scafy. So my preference is to perform surgical hip dislocation, and actually it's modified procedure to reduce the femoral head. And the history is about 3 months. So I prefer to perform modified down.
And what have you, that's always been your approach, Xuemin, or what would you have done 10 years ago?
In my hospital?
Yes.
10 years ago. Yeah, about 10 years ago, probably we will do in situ pin fixation, and sometimes we try to perform traction in Russo. It's a kind of Russo traction for about 3 weeks to see if any improvement of the femoral head reduction. Then we perform in situ pin screws.
So this is Xuemin's choice. And his preferred approach was the transtrochanteric, as Dr. Gans has shown us. And have you had any patients? This is a slip that should have no AVN complications with it. It's a stable, though severe slip, that's stable. Any problems with AVN with this stable slip in which you've done the Dunn approach for the severe deformity, Xuemin?
So far, I just not so many cases. I just performed about 7 cases. So far, I didn't find any AVN. But I think because I just to perform 7 cases, so I'm sure it will happen if I perform too many cases. So the indications in my department is very strict. For some severe cases like this one, we perform modified down. Otherwise, we just to do in situ fixation with screws.
And turns out to be a very nice solution to a complex deformity. So you've been satisfied, Xuemin. Nice job.
Thank you. Yeah.
I move on with a similar case. This is Ira, this is yours. 12-year-old presents with, I wasn't quite sure looking at the history, Ira, is this a stable or unstable slip?
This is an unstable slip.
Okay. And your thoughts on approaching this?
So I will try, if it's a physeal unstable slip, I will try to do a closed reduction. You know, I do it myself. I don't, it's as gentle a reduction as you can possibly do. And if I get a good reduction, then I'll pin it in situ and check the blood flow. If I can't, then if the physis is open and it's a high grade slip, I'll do a modified done typically.
And Ira has had a lot of experience with that. And I'm going to keep us moving here because we're going to talk about the unstable slip after we finish this case. But this case has an interesting second chapter to it. And your experience, this is an unstable slip. So your surgical approach is, as we see here, modified done. And his outcome was excellent. And have you had much AVN with the unstable slip with this approach, Ira?
Well, I think, yes, we have had AVN, and the patients in whom we have gotten AVN have been acute on chronic. So they already have a big deformity, and then they have a sudden disruption of their upper femur. And in those patients, my presumption is that the retinaculum is already stretched over a deformed upper femur, and the retinaculum tears when they have a complete disruption. So I don't really operate, I won't do a modified done on patients who have significant upper femoral deformity and then have developed an acute slip. I think it's too risky.
So, but the interesting thing is, I think the second chapter for this patient went back to activities and shows up about a month of hip pain. And for all those on the Zoom call, what's your diagnosis with her other hip? It's a very simple problem. If you put on Klein's lines, they're pathological in the sense they don't intersect any of the epiphyses, particularly in the AP X-ray. So I was diagnosed as an early acute slip.
I was going to ask Ira if this is an unstable hip in a 12-year-old. How do you choose who to perform a contralateral pinning or at the same time?
I do a contralateral pinning on patients who are at high risk. So if their triradiate cartilage is open, or if they have any endocrinopathies, I do an in situ pinning. If they're under 10, I do a contralateral in situ pinning. This patient's father didn't even want her to have any surgery, so I didn't even broach the subject of pinning the other side, but I probably would have pinned the other side under normal circumstances in this patient.
Assuming this patient was back playing sports and kind of ignoring things for a while, because let's look at what Ira found when he did a scope on this patient. So,
speaking of Perry, I have one question for them. When do you think that one pin, one screw is sufficient? When would you consider that you really need to use multiple screws? Has anybody got some philosophy on that?
Dr. Nepple?
So we tend to use 2 screws anytime it's unstable to maximize stability. I've definitely seen cases of progression from outside where 1 screw was used. In a stable slip, I think 1 well-placed screw seems to always be pretty adequate.
I agree with what Jeff just said. It's a femoral neck fracture. And I don't think you would ever take any other femoral neck fracture and do just 1 screw. I think there's an aspect of the derotation component to that to make sure that in flexion and extension, it doesn't just rotate.
My theory is that I would use it if there's any endocrinopathy. So if they have any endocrine problems, I would go ahead and that's the ones I put the multiple screws in. And I agree, I would also, if it's a acute slip, I would, or an unstable slip, I would use multiple screws. But if it's a stable slip, I think you can get by with a single screw.
So going us fast forward, so to speak, for some reason you decided to look inside, Ira. You put your screw on. What was the reason for adding this nice procedure here also?
So she was had a really minimal deformity, but was very, 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 very painful. Her hip, she had almost like a septic hip-like picture. She was really, really uncomfortable. And what I didn't show there was like she had a massive hematoma in her joint. And you can sort of generally see how inflamed the hip was. And she had only had, a couple of days of symptoms.
Can you tell us what we're seeing here, Ira? Is
So,
this a torn?
we're just seeing the scope. You can see the labrum. It's pretty unstable and very, very, very inflamed.
Little bitty bump.
The bump is coming up next.
Yeah,
Ira, that looks just like an impingement inflamed hip, right?
Yeah, it does. It does.
The little bump can get in there though, right, Ira?
Sure can.
So here, what are we doing here then, Ira?
So we're doing a scope. We're doing a neckplasty. And what I'm showing here is that if you can, arthroscopically, it's very easy to see the physis, and you can see the physeal plate as I'm resecting a little bit of the epiphysis. And so based upon the anatomy, that you're removing the entire deformity.
Again, look up on the left. You can see the small bump that it's a big problem for the patient. You've been satisfied with the bumpectomies, acute situation like this, Ira? They didn't come back. Patients have done okay?
Yeah, I'm very happy with it. I think that the patients recover well, and we haven't had any problems with healing of the physis or with development of heterotopic ossification or instability. So it's been pretty effective for us.
And the follow-up was good for this patient. So let's compare. We got 15 minutes left, so we got to talk about instability. So we talked before about stable slip. By Loader's definition, stable slip, can't walk. And let's talk about the unstable slip. So we walk with a big deformity, but we're stable. Our physis has become unstable for this patient here. And with this instability, the fluoro, as John can talk to us a little bit as he goes, you can get different types of instability on the fluoro. And you've tried to quantify this a little bit. Could you comment briefly on that, John Schoenecker?
Yes, we did a study here that we have not published yet, that we took all of the x-rays preoperative that we knew from the intraoperative exam by fluoro, which were stable and which were not. And the best summary of that data is you can't pick very reliably off of the preoperative x-rays which ones actually are truly unstable. And with that, what we'll do is we do a fluoro exam in the operating room to make that decision. And the best way to think about this is that what Ira said before is so true, is that if the periosteum or the retinacular flap is intact in the back, the chance of having AVN with that and the ability to close reduce it is pretty good. If that is torn, you can pick that up on your exam. And those are the ones that A, are very hard to close reduce because it's ripped all the way around, and B, have the highest rate, we think, of avascular necrosis. So we do this fluoro exam to determine which one we have.
Then there's a question of speed of doing things. So with displacement, this is a great article by Peterson, Green, et cetera, years ago. There may be tear, there may be kinky, and this may be a matter of time and obstruction. It's a little bit hard to know sometimes, and it's rather debatable, I think, how fast you must do things. But I like to think that a close reduction should be done urgently and gently if you're going to do it. I don't think you have to do it at 3 in the morning, but I think you should move on with this. Unbelievable angiograms done, I think this is from Korea, there's no flow. Let's say it's kind of analogous to the article from Green, the Nightingale Green, on this angiogram. So they reduced it, and look at the flow they got. I don't know if anybody else has ever done this, but that may be a little bit what this is talking about up here also. So we'll just kind of move through this so we get to the parts I think the most critical. This is a patient, Dr. Gordon's, and he's doing trauma. Eric has done a lot of these, and he's had very little AVN, and he would take him to the OR as soon as he could. He uses the fracture table. He doesn't do a lot of fluoro work, looking at what we just said, but this is actually a patient of Jeff's, but it's how Eric taught us to just internally rotate and extend the leg. And talking forward, Eric, this is his screw, 2 screws here, okay, 2 screws for this unstable slip, to answer your question. And he had a little additional capsulotomy there. He's already done it with the screws, but he likes to put another drill down. So we want to get a safe reduction, and Dr. Jose Herrera has showed us that there's pressure in the joint. If you reduce it with the capsules intact, you probably increase the pressure. So doing some kind of a decompression is a good thing. Jeff, I'm going to move on here and we'll talk about your case here.
Perry, I would want to argue with you about not doing it at 3 o'clock in the morning. You can, from hip fractures, femoral neck fractures, Jack Chain has shown from Hong Kong that the length of time after the injury increases the incidence of avascular necrosis. So I would agree. I think that this probably ought to be done as soon as possible because, like I say, I think this is a fracture, and they've shown in femoral neck fractures that length after the fracture before it's treated does affect the incidence of avascular necrosis.
Colin, what decision did you come to in your career about the need for doing these sort of unstable slips, Dr. Mosley? The time-wise, the time clock.
Yeah, Perry, my approach was to do them at the first available time the next morning.
I would agree. The next morning. Okay. Well, we can debate that all day. So let's go on here. Thank you, Colin. So let's go on. Jeff, you want to take over here?
Yo quería hacer una pregunta al respecto. ¿Puedo, Perry?
Sure.
¿Alguien usa la técnica de Parch para reducir y colocar el tornillo?
We'll get to that later. Yes, it's coming. The case is coming up. Yes.
Okay.
Yes.
Espero entonces.
Okay, Jeff,
go ahead. So I think this may be a similar positional reduction. In our experience, positional reduction works very good. I've definitely had some cases where it doesn't reduce, and things like a Ledbetter can be more useful.
Here's your case, Jeff, and here's your post-reduction. There's your AP and your lateral. You were not satisfied with this.
Perfect. So this is one with that gentle positional reduction that we've done here for 15 years was not adequate. So John's done a lot of work with Ledbetter maneuver that I think has been a useful tool to add. A gentle Ledbetter maneuver when a positional reduction doesn't work is sort of step 2 for me. And if not, then we may be thinking about a modified done.
John, here you go. You ready?
Sure. So this is just stimulating that if you have the posterior retinaculum intact, is abducting out, flexing up to catch up to the flexion deformity, then internally rotating to lock it in will reduce that. And then this is with an epiphyseal unstable skiffy demonstrating that. And again, in doing this, much of this depends on if that posterior retinaculum is intact, as Ira was alluding to before. It's very nice how well that unlocks it and then reduces it. And one thing to point out is where we decided to go back to this was actually because of reading the Parsh paper. is if you read the Parsh paper, essentially that reduction is this, just with an open technique. And so that's one way to think of this is just a closed Parsh, which initially was described by Ledbetter.
So Jeff, you did that. And here's your next reduction, Dr. Nepple.
Yeah, so I think much better. So we're going to accept that. And I think this was about 3 a.m. if I remember right. So we're going to put 2 screws in and then do a capsulotomy. Pressure monitoring, I think, is sort of a new wave that can help us. I think it's still.
Jeff, so I got some of John's pictures and then we go back. Okay, here go, John.
So if you get anything either through the screw or you can put another wire like this down into the epiphysis, what a very nice way to do this is if you pull the wire and just put an arterial line that you cut the end of the tubing off, is that you often can pick up the epiphyseal waveform. It's a nice, inexpensive way of doing that.
Is this your line here, John?
Yeah, we just give a line to the anesthesiologist, and remember that the pulse pressure of the epiphysis really can be anywhere from about 1 to 5 millimeters of mercury. So it's an open circulatory system. You're not putting this in a vessel. So just remember that they have to zoom way in order to see that waveform. And in terms of an imprecise way of telling you how to do this, all you're looking for is a pulse that matches up with the arterial or the heartbeat.
This would be the intraepiphyseal pulse right here, Craig?
Yeah.
What do we got here, John?
Yes. And there's a variety of ways of doing this. And it's just to understand that the pulse pressure of bone varies so much, or sorry, the mean arterial pressure of bone varies so much depending on the anesthetic that they have. And so you don't expect a consistent place to look for it. You have to search for it.
Back to Jeff.
Yeah, so I think a good point on that, if you're going to start to do that, start to try that in some stable slips, because it's definitely a little finicky. Seeing it in stable slips will give you confidence in the setting of an unstable slip, because if it's negative, you sort of have the decision, are you going to change something, unreduce that, or those kind of things. So there's the pressure tip from a different type of kind of neurosurgical monitor that you can do similarly. And then we're going to do a capsulotomy. I like to do it with a cob up the neck, so scraping under the capsule and really feeling the bone. You can be pretty confident you have a moderate sized capsulotomy by elevating right at the intertrochanteric insertion.
Everybody gets a bone scan at 6 months or 6 weeks, right, Jeff?
Yeah, I think 6 weeks can be helpful because I don't think your rate of AVN is ever going to be 0 with this approach. Some of these kids have such delayed presentations that you kind of know it's not a good situation, but I think the bone scan gives you confidence in letting them move forward with weight bearing and other activities, because often they're feeling pretty good. They have mild deformities or no deformity at this point.
So Matisse, this is a very severe deformity, acute so. And your approach and your technique for this unstable type of slip?
Well, as it was mentioned already, for us, this will go into a Parsh technique that we perform through a transgluteal approach, a lateral transgluteal approach. We go into the hip and we put our finger and we perform the same maneuver that you already showed, but with our finger right there. So we feel that is a good reduction, and that's how we pin it.
One screw for unstable slips or 2? You always use one?
Yeah, we use one screw. We follow the theory that there is a tubercle already there in the physis that gives you the second point for avoiding rotation. So we try to avoid that rotation point that is the fissure tubercle in the proximal femoral epiphysis.
I'm going to move on, and this patient did great. And this is the what we need to conclude to complete this discussion of the unstable slips. So this very unstable slip was pinned in situ and then sent to us a couple of days later. And I don't think this is going to remodel. So we went to the OR and did a modified done. And dislocated, removed the screw, very carefully keeping the lateral retinaculum intact. The head becomes loose. We took callus off, shortened a little bit, particularly took off posterior callus. Reduced, stabilized, learned carefully doing this. It's a dangerous procedure. The blood supply is precarious. There was a nice retinacular Doppler. There was bleeding from the head. And for this patient, it worked out quite well. To summarize here, if we look at what's out there for AVN, historically, the real number from Loader's papers, 35, not 43. The work we've done with closed work has had a very low rate of AVN. Parsh had a very, very low rate of AVN. Surgical hip dislocation, open reduction. We got some experienced people. Martine, do you do the done procedure for the unstable slips?
Yes, I do. I do a lot, but I want to do a question to the other faculties. When you have this patient in OR, and you under anesthesia, we do the maneuver of close reduction. What is your limit between go with Parsh procedure, less invasive, and to go to the done procedure? For me, because for me, the limit is between, it's after the gentle reduction. I have a mild slip, perhaps I do the anterior osteotomy, I put my finger like Matthias shows, and I remove the osteoplasty of this mild displacement. But if I have a moderate or severe displacement after the gentle reduction, I go with the down procedure. What's your opinion about this? If you have an experience or you decide in OR previously?
We hear you, Gene. Okay, so John Schoenecker, I've asked you this same question a lot. What's the limits of the closed reduction? When do you need to do the done?
Martine, I think that the most important answer to that question is vascular, is to think like a vascular surgeon. Because if you have the epiphyseal vessels torn, and you will not have a pulse, and it also will be a difficult reduction because it doesn't lock in. And in that case, I think it's important to do an open procedure, not as much to get the reduction, as much as to do an epiphysiodesis in order to get blood supply to go from the metaphysis to the epiphysis.
The open procedure, John, is it done?
I don't think, yeah, you can say a done. I don't think we should necessarily be calling every open procedure a done, because it's really an open reduction. And so I think that you go to an open reduction if the vascularity is out, so you can look, as Ira said, to see if the retinaculum is torn. You can Doppler it. And if that is out, you need to provide a new way for the epiphysis to get its vascularity, which is what the epiphysiodesis does. So I think we all have to think like a vascular surgeon first in the cases of an epiphyseal unstable SCFE.
Ira, you've said you try closed reduction and you stick with it if you have okay vascularity. How do you assess it?
I use an arterial line through the screwdriver into the head of the screw, and you can see a waveform. It's super finicky in my experience and not completely accurate, but that's how I do it intraoperatively. And if I don't see a waveform, then I will go to an open approach. And I think that, and John and I have talked about this before, in these kids, the only possible way to save the epiphysis is to get metaphyseal blood flow, and you have to meticulously excise the physis and then provide secure fixation in order for metaphyseal bone to heal to the epiphyseal bone. And then you have to keep the kids off of the hip for 6 months at least until you see subchondral resorption of bone, which is an indication that you have revascularized the entire head of the epiphysis.
Your surgical approach is most likely the transtrochanteric flip, right?
That's what I do.
So variable, okay, and experience. Let me just finish this. Close reduction percutaneous. John has looked at their patients who are, they assess by physeal stable or not, and they get even a lower AVN rate if you go by physeal stable or not. So yes, Matisse, did you have a question?
Yes, I will add that if you see these results in your slide, probably this variable for surgical hip dislocation and open reduction is a surgeon variable. So it's very important that probably the first thing that you have to keep in your mind is that you have to pick the safest method that you are able to perform. So I prefer a not very nice X-ray with a safe head over than a very nice reduction with a head that is probably going to be in this 65%. So if you are going to perform one case a year of surgical hip dislocation, don't do it.
Agree. So let's finish by severity of AVN varies. Dr. Wilkins mentioned focal segmental AVN. So a reduction, and if you look here, there is a little AVN here. I would call this segmental AVN. It may or may not become a symptomatic problem. A more severe AVN, reduction, total hip necessary. This was through my one bad result from a partial approach. But if you get AVN with this, and this is our patient, and this was a very, very well perfused head, we thought we were done. You need to really have control of this patient. And I think Matisse mentioned this before. Dr. Gans talks about in his article, if you don't have control of the leg, he really says this, put him in a spica cast. This patient went home well-meaning, and he came back to see us about 4 weeks later without his crutches. And we were abhorred about what's going on. He said, well, I feel so good. And I think this is what happened. You crushed the vessel, and that was the outcome. And so again, I think you should learn the patient and know the patient, and you should, as Matisse just said, really understand what you can do and not do. It's been fabulous putting this together because we've changed so much and there's so many different things we can do. But I think the message to the attendees is, and kind of what Matisse just said, whatever you do, try to make it as safe as you can to avoid AVN. The rest of the things usually you can work around and they can have some life, but you can't have much life with this. So we left this boy after treating him. He moved out of state, and that's the way we left him, and this is the way he came to see us. So it's a humbling, humiliating experience. Any final comments about the faculty? Either Martine or Christian?
Perry, I would suggest that you're being too hard on yourself with the AVN in this case. I think the AVN is almost always established at the time of the injury, not at the time of the surgery. I think this patient, judging from the initial x-ray, was doomed from the start.
Thank you, Colin.
Anytime.
I think that, Pops, is one of the big take-home points, and Ira really highlighted that with the periosteal tear, and why I think it's important to take a look at these patients under fluoro when you get them to the OR, is that if there's no retinaculum intact and you can pick that up, you need to understand that you're already behind the 8 ball, as Dr. Mosley just said.
Peter, any comments?
No, I agree with all of these good points, and with Colin in particular.
Matisse?
I think I already say the message that I want to put on here, that keep the hip in your head, as Dalia Sepulveda says always, and keep it safe. That's my message.
Deborah?
Nothing. No, I agree with everything. It's a very potentially devastating condition, not always helped by the treatment.
Lydia, we thank you again so spectacularly working with Adriana for sticking with us for 10 minutes overtime. Any final comments? Let's see, Jeff, do you have any final comments? Nepple?
No, thanks, Perry, for putting this on. I think that's a great whirlwind through all the aspects of SLEPs.
And our mentor from the great Garrahan, Bibiana, any final comments? Bibiana Della Rosa, thank you for making this all possible, Bibiana.
Yeah. Perry, I have one comment.
No, hay que solamente agradecer a los fellows que estuvieron acá presentes por alguna pregunta, y muchas gracias a todos ustedes porque los aspectos que tocaron fueron amplios y excelente las fotografías y casos. Muchísimas gracias y los esperamos el mes que viene.